Hello, I'm Himani Murdeshwar, a junior doctor in the anesthetics department at the Barts Trust in UK.
And I'm Namrata Sethi, an IMG from India and a 2023 match applicant. Today, we'll be presenting on techniques for bedside teaching in the emergency room.
There are rising concerns over the decline in bedside teaching in modern medical education, resulting in the loss of valuable teaching modeling from senior clinicians. This is especially so in emergency medicine and is attributed to time constraints, frequent interruptions, and faculty inexperience. A national survey into the state of undergraduate education in emergency medicine suggests that while 90% of programs involve residents as teachers, only 45% provide instruction in effective teaching methods. That prompted us to undertake this project.
The literature that we reviewed through our search on PubMed and Google Scholar gave us some important tools and techniques that can be used in the ER. Here are a few of them that stood out.
Resident as teacher. Dedicated teaching shifts allow senior residents to improve their teaching skills. These are invaluable when accompanied by checklist based feedback from experienced faculty members. Integrating technology. Bedside rounds remained elusive during COVID until some educators began conducting virtual rounds using an iPad with a computer on wheels. Paired with a video conferencing platform, clinicians can now educate the generation of digital natives in a pandemic proof manner. Bedside presentations. This old school technique will never go out of style as its unique learner student patient dynamic makes for an immersive educational experience. With a rising focus on patient centered care, bedside presentations remain integral to medical education, but require adapting to the ED using some efficient frameworks for teaching.
2-minute observation is a time efficient strategy which involves the teacher being a fly on the wall. The learner talks to the patient, and the teacher just slips in and out of the encounter without intervening. This helps the teacher gather more direct information about the learner's improvement needs with minimum disruptions. Next up, there's Me Plan. You can see the full form here. M is for a preparatory meeting between the teacher and the learner before the patient encounter, just to set goals. The I refers to behaviors for the teacher to adopt during the learner's bedside presentations. Inspect the patient to confirm the findings, encourage independent thought in the learner, and the plan is an algorithm for patient care, learners' questions, attending's agenda, and next steps. This helps the teacher be confident in their ability to teach because they have a plan, pun intended. The last one is activated demonstration. Here, the topic of discussion is defined to the learner as an assignment before the actual process. For example, how to break bad news to the patient. The learner then observes their teacher in action, and this is followed by the teacher asking the learner to describe what they just observed, and then the chosen approach is discussed.
What more can one do to improve the teachable moments in ED? Try out the Aunt Minnie model, which states that if the lady walking down the street looks like your Aunt Minnie, then it must be her. Learning through pattern recognition is quite useful in an ED with a high turnover. Think you've got a minute to teach? Why not share a quick clinical pearl using the 1 minute preceptor? Encourage your students to develop time critical decision making abilities through snaps, where you delve into a particular case and work through a list of differentials to come up with a plan and select areas for future research and learning.
To sum up, we need teaching tools to help make judicious use of time while being sensitive to the learner's needs and to decrease over reliance on investigations. We also have supplementary tools like the ones Himani just mentioned. We have checklists and observation forms that could be used for assessment and feedback. Having said that, we also need to be mindful of the limitations of these tools. Technical challenges may arise with video conferences. We all know that. And there could also be an impact on the patient's confidence in the trainee doctor. But this can be avoided by the faculty asking questions only to those not directly involved in caring for that patient.
In conclusion, we would like to recommend adopting a learner centered approach with the provision of individualized supervised learning and feedback, empowering students to develop a questioning mind through the use of what if scenarios and up the ladder techniques. asking the same question to progressively advanced learners. These supplementary tools, used in combination with traditional teaching techniques, have a synergistic value that takes the teaching session up a notch. Last but not the least, a stronger focus on molding residents into clinical educators with a diverse toolkit is the need of the hour.
That is all. Thank you for tuning in.
If you found our poster useful, please share it with fellow healthcare professionals and reach out to us on our Twitter handles with the hashtag #TeachWithTools. Thank you.
Thank you.